Dear all, welcome to this lecture. I will talk in this lecture in details about tumor lysis syndrome. I will cover pathogenesis and diagnosis, then I will talk about prevention, treatment, and then finally our test. Starting by pathogenesis and diagnosis, it is well known that patients with cancer cell lysis may occur if the patient received chemotherapy, radiotherapy, and even it may be spontaneously without the receiving of chemotherapy or radiotherapy, especially in large-sized tumors. So when patient is exposed to chemotherapy or radiotherapy or sometimes spontaneously, there may be cancer cell lysis, and the contents of the cell will go out into the blood. When there is cancer cell lysis, there will be hyperkalemia due to the outflux of the potassium from the cell compartment into the extracellular compartment in the blood. There will be hyperphosphatemia, and hyperphosphatemia will cause hypocalcemia because the more the phosphate, it will combine with calcium, causing precipitation of calcium and the hypocalcemia. Also, due to cancer cell lysis, there will be nucleic acid breakdown of the cancer cell itself, and this will release hypoxanthine. By xanthine oxidase, it will be converted into xanthine, and again by xanthine oxidase, it will be converted into uric acid with low solubility. Later on, there may be renal dysfunction. Why patients with cancer cell lysis and tumor lysis syndrome may have renal dysfunction? This may be due to several factors. First of them may be due to uric acid nephropathy due to the high level of low soluble uric acid in the blood due to purine catabolism in these cases. The second may be nephrocalcinosis due to deposition of calcium in the renal tissue secondary to hyperphosphatemia. Then it may be obstructive nephropathy due to deposition of uric acid or calcium in the kidney. Xanthine nephropathy due to allopurinol therapy. How hyperkalemia presentation is? Hyperkalemia may be presented by ECG changes, arrhythmias. Also, it may affect the nervous system and the muscles, causing paresthesia, weakness, and myalgia. The presentation of hyperphosphatemia may be in the form of, as we said, secondary hypocalcemia. Hyperphosphatemia itself, phosphate may deposit in the kidney, causing renal failure. It may cause seizures and also may cause rhythm abnormalities and cardiac arrhythmias. Regarding the hypocalcemia itself, also may be presented by ECG changes and arrhythmias, also paresthesia and muscle cramps, and finally, in severe hypocalcemia, there may be tetanus. Okay. How to diagnose cardiorenal syndrome? There is a criteria called Cairo-Bishop definition for tumor lysis syndrome, where there is clinical criteria and the laboratory criteria must be present to diagnose tumor lysis syndrome. Whatever the laboratory criteria or the clinical criteria, they must be presented within 3 to 7 days after chemotherapy initiation. In the laboratory criteria, the presence of at least two parameters of these laboratory criteria are enough to diagnose tumor lysis syndrome. And the two laboratory criteria changes must be occur within 24 hours from each other. What are the laboratory criteria? High uric acid level, potassium level, phosphate level than normal, or even increased 25% more than their baseline before chemotherapy or radiotherapy. Also, hypocalcemia, calcium less than or equal 7 mg per deciliter, or decreased 25% from its baseline before the chemotherapy or radiotherapy. So if you have only two laboratory criteria from these four criteria, it is enough to diagnose laboratory tumor lysis syndrome. Regarding the clinical criteria, it is enough to find only one of these clinical criteria beside the two laboratory criteria to diagnose tumor lysis syndrome. What are the clinical criteria? The presence of renal dysfunction, acute kidney injury. Usually this definition is not used. you have to use the definition of acute kidney injury that I mentioned in first lecture of this course. Renal dysfunction, cardiac involvement, arrhythmia, seizures, and tetany or death. So to diagnose tumor lysis syndrome, you must have at least two clinical criteria and two laboratory criteria and one clinical criteria. So that was about the pathogenesis and diagnosis and clinical presentation of tumor lysis syndrome. The next point is how to prevent tumor lysis syndrome. To prevent tumor lysis syndrome, at first, you have to prevention is to identify risk patients. There are some risks that are related to the tumor itself and some risks that are related to the patient himself. Regarding the intrinsic tumor-related risk factors, which tumors are at risk of development of cell lysis and tumor lysis syndrome, tumors with high cell proliferation rate, tumors which are called high-risk cancers, tumors with a larger size more than 10 centimeter, and the chemosensitive tumors. Actually, the oncologist and the hematologist have more knowledge more than us as a nephrologist regarding this part, and usually the physician that deal with the prevention of tumor lysis syndrome is the oncologist or the hematologist, not the nephrologist. Usually oncologist and hematologist consult nephrologist when tumor lysis syndrome develops. So the prevention mainly is the job of hematologist or oncologist. Which tumors we can say that they are high-risk cancers. We have high-risk cancers, intermediate cancers, low-risk cancers. I will not go in depth through this table, but the type of cancer here, you have different type of cancers, and when they are considered as high, intermediate, or low cancers, so the high-risk cancers are at risk of development of tumor lysis syndrome. What are the patient-related risk factors that increase the risk of tumor cell lysis? If the patient is already having pre-treatment hyperuricemia or hyperphosphatemia due to any cause, if there is pre-existing nephropathy in the patient already has renal impairment before receiving the chemotherapy or radiotherapy, if the patient is oliguric, if the urine is acidic because uric acid is precipitated in acidic media, or if the patient is receiving any nephrotoxic drug, and finally, if the patient is in inadequate hydration, the hydration is inadequate, the patient is dehydrated. Okay, after identification of patients at risk for the development of tumor lysis syndrome, what is the next step? The next step that we must do a very good pre-hydration. The patient must be hydrated. The most common solution used for hydration is 0.9% sodium chloride, normal saline, about 2 to 3 liters per meter square, about 4 to 5 liters per day, for 48 hours pre and for 48 hours post chemotherapy and radiotherapy, aiming for urine output more than 3 liters per day. But beware of volume overload if your patient is a renal patient or cardiac patient. Regarding use of diuretics, can we use diuretics to maintain urine flow in these patients? Actually, some books write that you can use diuretics to maintain urine flow in patients for prevention of tumor lysis syndrome, but it is better to avoid because diuretics acidify urine, and acidification of urine will increase uric acid precipitation and increases the risk of tumor lysis syndrome. So it's better to avoid the use of diuretics. The third point for prevention after identification of patients at risk and after pre-hydration, the third point is to prevent uric acid formation. If the patient is low to moderate risk, you can use allopurinol or febuxostate to prevent the conversion of hypoxanthine to uric acid, which has low solubility. Febuxostate can be used by a dose from 80 to 120 milligram per day. Allopurinol can be used by maximum dose of 800 milligram per day. Both can be used 2 days before therapy, and you have to continue it after the radiotherapy or chemotherapy. There is intravenous allopurinol. If it is available in your hospital, you can use it. But if the patient has high risk for tumor lysis syndrome, it's better to use rasparequis. I talk about rasparequis more and what is its mechanism of action more, side effects and dose of administration while I'm talking about treatment tumor lysis syndrome. But now we can say that rasparequis rapidly decreases the level of uric acid by converting uric acid to the more soluble, highly soluble allantoin. I will talk more about rasparequis while I'm talking about treatment of tumor lysis syndrome. The next point for my lecture is treatment of tumor lysis syndrome. What if the patient developed tumor lysis syndrome? First of all, you have to be aware and you have to follow electrolyte disturbances with laboratory tests every 4 to 6 hours. You have to monitor the cardiac condition of the patient and be aware of hyperkalemia. If there is hyperkalemia, you have to treat hyperkalemia. We will later discuss management of hyperkalemia in another course, which is called acid-base disturbances and electrolytes course. But for now, for management of hyperkalemia, if there is ECG changes, you have to use calcium gluconate to protect the heart from hyperkalemia. Then you can use other measures to decrease potassium level in the blood by using sodium bicarbonate, insulin glucose, cation exchange resins, diuretics maybe, and finally maybe dialysis. But we will talk in depth more in hyperkalemia and its treatment in the course of electrolytes and acid-base disturbances. The second point regarding the hypocalcemia, have we to treat hypercalcemia? The answer is no, because with treatment of hyperphosphatemia by hydration, usually hyperphosphatemia resolved by hydration, hypocalcemia will be corrected. So don't treat hypocalcemia except if there is neuromuscular instability, convulsions, or cardiac arrhythmias. So there is no need to treat hypercalcemia because correction of hyperphosphatemia will avoid calcium phosphate precipitation and correct calcium level. And this is the same point that I will mention later in the lecture of rhabdomyolysis. We will have the same concern in rhabdomyolysis because in rhabdomyolysis the patient will have hyperphosphatemia and hypocalcemia too, and we will not treat hypocalcemia except in cases of tetany, neuromuscular instability, ECG changes, arrhythmia. After we talked about hyperkalemia, hyperphosphatemia, and hypocalcemia, one of the most important points of treatment of tumor lysis syndrome is to continue volume expansion by normal saline to maintain high urine output to wash uric acid precipitation, phosphate precipitation into the tubules. Then you can continue allopurinol and ethopoxystate to convert hypoxanthine to prevent the conversion of hypoxanthine into uric acid. Regarding alkalinization of urine, it is logic to alkalinize urine to dissolve uric acid in the tubules because we said that uric acid is precipitated in acidic media. So by alkalinization of urine, we can make uric acid more soluble and be excreted in the urine. But actually, this must be not used because by alkalinization of urine, you will use sodium bicarbonate intravenously, which may cause alkalosis, and alkalosis will precipitate more hypocalcemia and precipitate convulsions and tetany and more complications. So don't use bicarbonate to alkalinize urine. You can use only bicarbonate if the patient has severe metabolic acidosis. So we'll use bicarbonate to treat severe metabolic acidosis, and there is no rule to alkalinize urine and use bicarbonate to dissolve uric acid in the urine. The next point, you can use rasparequis. Rasparequis is the recombinant form of the enzyme urase oxidase. Urase oxidase is not present in our body. It is present in some species, but not in humans. RAS pericase oxidizes uric acid into allantoin, and allantoin is very soluble. RAS pericase rapidly decrease the uric acid level even within 4 hours to undetectable. It is very effective and very powerful. We said that we can use this treatment of tumor lysis now, and we said that it can be used in prevention of tumor lysis syndrome, especially in high-risk patients. Regarding RAS pericase, it is usually given as 200 microgram per kilogram intravenous over 30 minutes daily for 5 to 7 days. There are some shorter protocols to use RAS pericase, including single dose, but it is very expensive. RAS pericase must be avoided in patients with glucose 6-phosphate dehydrogenase deficiency, and RAS pericase has no dose adjustment. By the way, allopurinol has dose adjustment. Roughly, it must be decreased by 50% if the patient has a renal impairment. Fevoxystate is usually has no renal adjustment. Regarding side effects of RAS pericase, side effects are in the form of rashes, GIT upset, and headache. Finally, regarding the treatment of tumor lysis syndrome, hemodialysis may be indicated if there is any indication of acute kidney injury for hemodialysis. So if there is any indication appeared for dialysis, you can start dialysis for these patients. Okay, after we finished the lecture, we talked about pathogenesis and diagnosis, prevention, treatment, and finally now test yourself. You can pause the video and try to solve the case before I solve it. Please pause the video. Okay, this is a patient presents with criteria of tumor lysis syndrome. Yes, the case may be not that accurate because it didn't mention that the patient received chemotherapy or radiotherapy, but I said that tumor lysis syndrome may occur spontaneously. So which of the following therapies is contraindicated in this patient? We said that urine alkalinization is not preferable in these cases because alkalinization of urine will be by alkalinization of the blood, and alkalinization of the blood will cause more hypocalcemia with more complications. So don't use sodium bicarbonate except if there is severe metabolic acidosis. Use bicarbonate to treat the metabolic acidosis itself. You can use intravenous saline for sure, RAS pericase, and allopurinol. The second case. Okay, this is a case with 40-year-old gentleman from Somalia, has fever, bilateral large axillary, submandibular, and inguinal lymph nodes. They are biopsied, and he started on treatment. He started on high-dose dexamethasone. Now, the white count is high, platelet count is normal, serum urea is high, serum creatinine is high. So patient with acute kidney injury or with kidney injury after treatment of a tumor, this will diagnose tumor lysis syndrome, and for sure the best treatment is RAS pericase and normal saline. I know that there is normal saline and allopurinol, but we said that RAS pericase is more effective. So if I have the option to choose allopurinol or RAS pericase, I will go for RAS pericase because of its effectiveness and its effect to decrease the serum uric acid into undetectable within 4 hours. The third case, he is asking here, what is the most likely cause of acute kidney injury? The answer is tumor lysis syndrome. Why it is tumor lysis syndrome? This is a male who is 59-year-old, treated with CHOP technique for non-Hodgkin lymphoma. The patient received cyclophosphamide, doxorubicin, prednisone, and vincristine. And now the patient is presenting by vomiting. Okay, and if you check his lab investigations, you find high creatinine, low GFR, high urea, normal sodium, high potassium, hypocalcemia, hyperphosphatemia. Lactate dehydrogenase is high. It may be high also in cases of tumor lysis syndrome because of the lysis of the cells. With any lysis of any cell in our body, LDH may be high. Total bilirubin is normal. That's why we exclude microangiopathic hemolytic anemia. By the way, we will talk about microangiopathic hemolytic anemia in another course called kidney and systemic diseases. We will talk about it in details. Finally, you find white count is high for this patient. So all of these criteria are more diagnostic of tumor lysis syndrome. No pre-renal injury, no sepsis, not vasculitis. It is a classic history. A patient with tumor who received chemotherapy and now is presenting by a kidney injury with hyperkalemia, hypocalcemia, hyperphosphatemia. So it is more diagnostic for tumor lysis syndrome. Thank you for watching this lecture and see you in the next lecture.